The kind of movement over the last 10 to 15 years with prostate cancer is just astounding. And all of those wonderful trials that we just went over very elegantly are all moving to doublet therapy. But this newest kind of push has been the idea of, can we grow on top of that with triplet therapy? Now, the issue with the triplet trials is that they're all building on top of the docetaxel backbone. And so looking here at piece one, as a triplet trial, and also the Arasins that we've gone over that's docetaxel with darolutamide as a trial, but all of those have a ADT plus dosi as their backbone. And so with those, the mean is continuously moving further out in time. Left click, no work. There we go. So the real issue, though, that almost all of us face with a patient in the room is, when do I add docetaxel to the fact that I'm going to give you an ADT plus an AR doublet? And that just has not been answered in the trial. So there's a lot of back-end analysis of the data to try to suggest if one of those is better or not. And then we use patient factors to choose who we're going to intensify on top of doublet therapy. And then there's some emerging work on tumor factors that may push us towards intensifying on top of doublet. So there were a couple of meta-analyses that were run off of doublet trials and then updated with the newest publications of some of the triplet data. In general, kind of the original overall cohort showed there's an improvement with triplet that's more than necessarily with the doublets. But of course, they were all much better than just ADT monotherapy. If you really look at the high volume cohorts, that's where the most improvement with triplet has been noted kind of consistently, going back to even the docetaxel data. And with the update after Arasin's publication, you can see the Daro triplet was superior, even slightly higher than that of the Abbey triplet. So we don't really have a great answer on, is it for sure better in every patient, but we think younger patients that may tolerate it with high-risk disease, high-volume disease, and potentially visceral mets are going to be the best patients to potentially proceed with triplet therapy. But then we have other things that can help us, genetic signatures. There's potential future updates on this, including PSMA, SUVs potentially as a predictor, volume categories based off PSMA, not just off of high volume, low volume from conventional imaging. And then there's a lot of emerging work on using AI signatures from PATH, as well as potentially genomics that might suggest that they're going to be a better triplet candidate. So I just want to touch on a couple of specific tumor mutations that may impact selection of triplet over doublet. Thankfully, it's already mentioned, so I don't have to go over all the word salad here, but TP53, P10, RB1 are all kind of negative predictors in terms of prognosis. SPOP is a mutation that actually is almost a positive for a patient, that it suggests that they have high likelihood of responding to AR-directed therapy. So a little bit of the data behind those. TP53, RB1, and P10 is kind of following off the idea of the triple negative breast cancer idea. If you've got these mutations all bundled together, those patients tend to be more aggressive. Looking at a large PATH data set, this is just an example of how this is enriched as men have progressive disease. So the triple aberrant prostate cancer was up to 40% of those in the metastatic setting, which are these kind of getting to these blue where you're having all three mutated. But in primary disease, it's very unlikely you're going to have a triple metastatic or a triple aberrant prostate cancer. It tends to be associated with worse clinical outcomes. And in fact, if you look at these curves, this is triple aberrant versus no triple aberrant. And honestly, 3 mutations is worse than 0, 1, or 2. So it's basically the additive effect of all of these mutations is even the worst outcome. And then for TP53 mutations, wild type versus mutated, this is an MCRPC data set looking at mutated patients having a worse survival curve than those who have a wild type TP53. So all these are beginning to point to a picture of the genetics are just important as the kind of H&E stained pathology slides that we use for diagnosis and risk stratification. So selection of a doublet agent if there's a mutation, looking at metastatic castration-sensitive prostate cancer patients. This was a retrospective trial looking at ADT docetaxel compared to ADT plus abiraterone. You can see here, these are the tumor suppressor genes and their mutation rates. So still not a high rate, but certainly 30%, 1 in 3 patients having either a P10 or a TP53 mutation is fairly high. You can see only 2%, thankfully, in this cohort were the triple aberrant. So looking at those, it was fairly split who ended up getting abiraterone and who ended up getting docetaxel. If you had a TSG alteration, this is progression-free survival, and this is no TSG alteration. And then this is PFS 0 greater than 2 and 1 TSG alteration. So basically, any sort of mutation along those in that tumor suppressor genes portends a worse outcome in terms of progression. Really no difference if you've got one or more than one. It's just really any mutation in any of those 3 genes portended a worse outcome. And then when they compare between the different treatment arms, those that were that had no tumor suppressor gene mutations had the best outcomes with the ADT plus abiraterone. And if you had a mutation, you had poor outcomes looking at survival here. These are the 3 curves for basically mutated patients, whether DOSI or abiraterone. There's a lot of overlap. So there's really, it's not unfortunately able to say that you need to get docetaxel if you have a mutation. You just do poorly with both treatments. Now, kind of the contrary to that are SPOP mutations. This is a large Flatiron database. You can see here over 1,000 patients, about a 10% rate of having SPOP mutations. And then this is time to CRPC on an AR agent, and this is time to CRPC on a docetaxel. So much faster time to castration-resistant progression if you were, it's a much longer kind of prognosis for the patient if you're on an androgen-targeted agent versus if you're on docetaxel, you have kind of the progression in a much faster rate. So those, basically the patients who were treated with an AR-targeted directed therapy was much more favored if you were a SPOP mutant. If you were wild type, there was really no difference between those getting docetaxel or getting abiraterone, and that was seen also with the overall survival as long as, in addition to the CRPC outcomes. So this was, I just took this out of a recent ASCO publication from last year, really looking at this. This is now a common question, is who is the best patient to get triplet versus doublet? I think we kind of run this through our heads on every patient that's in our clinic with this situation. And as kind of was gone over earlier, there's those that are kind of sit in the middle where you could probably kind of do whatever you want, but the ones who tend to be higher volume, higher synchronous disease, presenting with a higher volume and burden of disease, triple negative patients who do not have a good PSA response to ADT initiation. So if you started it and they didn't have it, you would consider adding in docetaxel at that time point. And they also mentioned the patient factors, younger patients or patients that are very fit. Doublet therapy tend to be more the less of a performance status patient, lower volume or metachronous, so a slower timeline of recurrence of their metastatic disease. Presence of SPOP mutations suggests that doublet may be adequate and you may not need the added toxicity of triplet. So my take home for this is that basically all of this intensification of therapy comes with a trade-off and the caveat of additional toxicity. So the outcomes may be improved, but if you can't get patients through the therapy, it may not be the right thing in that situation. But we tend to recommend triplet over doublet in higher versus lower volume disease. And certainly if they have any of those somatic or germline mutations that would put them at higher risk, that's something that would play into that decision that might move the needle one way or the other. And then rare as it may be to see, I've only seen it a handful of times in my own clinic, SPOP mutations, that's an ideal patient to potentially be on doublet therapy and forego docetaxel. So, and I also bring this up just because the future is going to change. There are multiple trials looking at additions of other agents in the frontline setting. Triplet is not just going to be ADT plus an AR agent plus docetaxel. So we need to come up with terminology that's appropriate because just saying doublet or triplet is not really going to be the right language in just a few years. We're very likely that we're going to have other things that are available in this metastatic hormone sensitive setting. So with that, I thank you, and I guess I'll be back up here in just a minute.